Hello and welcome to our APS360 final project presentation. We are Team 30 and we're going to be going through our lung cancer and COVID-19 detector. My name is Yusuf Saad and I'll yield the floor to my teammates for them to introduce themselves.
And I'm Saeed Abdul Wahab.
I'm George Kyrgyz.
Mazen Ismail.
Before we begin, do you think you have what it takes to be a radiologist? In front of you are three patients. They could all have COVID, they could have cancer, or they can be healthy. Who knows? But you're going to be making a prediction, and I'm going to reveal the answer very soon.
Looking ahead, we'll start by introducing the problem as well as our goal. We'll look at our data and how we processed it, the model and the architecture, and finally, we'll look at the results. In the past 5 years, over 16 million lives have been lost to COVID and lung cancer alone. We can't argue that diagnosing these illnesses aren't easy, and even experienced doctors face problems. According to our research, we found that doctors may have a 4% to 30% chance of having an error in diagnosis given a chest x-ray. This can be due to the stage of the illness, the size of the tumor, or the position. Sometimes it's simply not visible to the naked eyes of a human doctor. But we realized that even a couple college kids can help. That which an eye can't see, a convolutional neural network can. We realized that by using deep learning, a machine can see features in the image that even a doctor may not pick up. And so our goal was simple. If on average a medical professional can have a 15% error rate in diagnosing diseases in a chest x-ray, then we want a greater than 85% accuracy and save lives.
Now we will talk about how we process the data before training. First, we gathered X-ray images from two Kaggle datasets, the COVID-19 radiography database and the NIH chest rays dataset. To ensure consistent and balanced data, we selected 3,616 unique images for each category: COVID-19, lung cancer, and normal. These were resized to 299 by 299 pixels to standardize input dimensions. Each image was then labeled appropriately for supervised learning. This process ensured that our dataset was clean, balanced, and ready for modeling. Our dataset was then split into 70% training, 15% validation, and 15% testing sets. This ensured a fair and unbiased evaluation of the model. To maintain the integrity of critical details, especially in cancer x-rays, we avoided data augmentation like rotation or flipping, since the input is always in the same format. Augmentation might have risks altering small indicators of disease, potentially leading to misclassification. By balancing the dataset and keeping all images in the original orientation, we ensured consistent and reliable inputs. To enhance model efficiency, we used the VGG16 network for transfer learning. This pre-trained model allowed us to transform our x-ray images into high-level feature maps, capturing essential structural patterns like abnormalities in the lungs. By leveraging VGG features, we reduced model complexity while improving accuracy. These feature maps allowed the model to focus on the most critical aspects of each image, accelerating training and enhancing generalization.
Next, I'll go on to explain the overarching model architecture that we used and some of the reasons as to why we made these decisions. As Mezen explained in the previous section, we first extracted the features using a pre-trained VGG16 model, which processes the high-dimensional input X-ray images and outputs a feature map of size 512 by 9 by 9. This was done as VGG16 is pre-trained on the ImageNet dataset, which consists of millions of images across thousands of categories. This means that it has learned a wide range of low-level features like edges and textures, which makes it useful in medical imaging. It has 13 convolutional layers followed by 3 fully connected layers, which makes it especially effective at capturing complex patterns in images. We put it before the CNN due to data scarcity, as medical datasets often have limited labeled data due to privacy concerns. Transfer learning allows the model to generalize well, even with relatively small datasets. Then we pass these features into a feed-forward classifier designed to predict three classes: lung cancer, COVID-19, or neither. So I'll be going a bit deeper into the architecture of our classifier. We begin with a flattening layer that takes an input from the VGG feature extractor and outputs 41,472 neurons. This then passes through the first fully connected layer, after which it undergoes batch normalization, relu activation, and a 30% dropout, culminating in an output size of 256 neurons. The second layer is the same as the first layer, outputting 128 neurons, but without dropouts. And the final layer is also our output layer, where we produce three logits, one corresponding to each class that the model has predicted.
And finally, we will show and discuss the results of our final model. Before we get to the numbers, let's discuss the choice of our metrics. Especially in the context of a medical problem, we have to be very careful on how to analyze the model. We begin by using precision, which measures how many predicted positive cases are correct. If too low, it can misclassify a healthy individual as having a disease. Secondly, and definitely most importantly, we use recall. Recall is a measure of how many actual positive cases are identified. A low recall means we may miss a diagnosis of a person with cancer. And so we also look at the harmonic average between precision and recall, which is called F1 score. And finally, we look at accuracy, which is an overall depiction of our model. Looking at the numbers, we can see that cancer is particularly found well, while normal and COVID are not found as well, especially looking at the recall number, which we discussed was the most important.
So we're going to be looking at the confusion matrix that we built here. So we look at the diagonal, it is a very dark blue telling us that the model does precisely predict the classes. But then we look at the off diagonals for normal and COVID, we see that the model actually confuses them a lot with each other. And that could be due to the nature of COVID being hard to detect through x-rays and sharing similar features with normal, making the model have a hard time predicting it. Whereas cancer, on the other hand, involves a physical obstruction in the lung and makes it easier for the model to predict. I hope you have your guesses locked in because now we're going to be predicting what each patient has. So we run a quick little script where we feed the images to our network and we see that patient 1 has COVID, patient 2 has cancer, and patient 3 has normal lungs. So what do you say? Can you be a radiologist? Moving on to something a little bit cooler is taking a look at where the model is sensitive to the most. So we take a look at normal, it's all over the place. It doesn't really focus on a specific region. But for COVID, you can see that the left lung is a bit highlighted and the right lung is also a little highlighted, showing that the model is sensitive to those areas a lot. And for the cancer, the right lung, where there is some mass, we can see that the model is paying attention to it. Moving on to our demonstration. Now, obviously, we were a little bit biased. We showed you 3 patients that we knew the model was going to predict right. So now we run our test loader, which is completely foreign to the model, and have it classify that for us. We're going to run a script, which just takes in the test loader, and we extracted the features. We pass it into our network, and we're going to see what it outputs. So we see we have 537 for COVID, 558 for normal, and for cancer about 541. And it gets a lot of them correctly, and we see that this aligns with our validation set, and the confusion matrix for the validation is pretty high all around for all the classes. With that being said, that's our presentation for Team 30. Thank you so much for listening, and we hope you enjoyed.